before that, I think we need to have a condolence to all the
Yeah.
doctors who tragically passed away in the air crash thing. I personally feel that we should observe a
Okay.
moment of
Let us have
silence.
a 1 minute silence,
Yes,
please.
sir.
Yes.
Yes, sir. Yes, sir.
Om Shanti. Om Shanti.
Om Shanti Shanti.
Om Shanti. Yes, sir.
Apurva, let us start. Parth is there? Yes.
Parth?
Yes.
Share your
Yes.
slides, please. Okay. So as usual, we'll have a let him finish his history and history summary. Then we'll have a discussion followed by examination, summary of whole case, and then the further discussion. Parth, let us start.
Yes, sir. Good morning, everyone. I am Dr. Parth Kotia, presenting a case on thyrotoxicosis under guidance of Dr. Pankaj Modi, sir, Dr. Apurva Shah, sir, Dr. Maulik Mehta, sir, Dr. Hiral Chauhan, ma'am, and Vineet Chauhan, sir. In 36-year-old female patient residing at Ahmedabad, housemaker, and belonging to lower socioeconomic class, presented in OPD with the chief complaints of swelling in the neck since last 2.5 years. On elaborating ODP, patient was relatively asymptomatic before 2.5 years, and then she noticed swelling in front of neck, initially smaller in size and gradually increased to current size, which was not associated with the pain or fever, associated with the weight loss of 10 kgs over 2 years, despite of good appetite, and protrusion of eyes since last 2 years, excessive sweating, intolerance to heat, and difficulty in falling asleep since last 2 years, which was not associated with the palpitation or breathlessness, change of voice, difficulty in swallowing of food, lower limb edema, sudden increase in size of the swelling, or any other swelling in the neck. Patient consulted physician for similar complaints. Blood reports were done and started on medication since last 2 years, followed by which some of the symptoms were improved but not resolved completely. In past history, patient is not a known case of diabetes, hypertension, or tuberculosis with no history of any radiation exposure. Patient was operated for tubal ligation 6 years back. Patient has no significant family history. Patient takes vegetarian diet. Patient's bowel and bladder movements are regular with good appetite, and occasionally patient has difficulty in falling asleep. Patient's last menstrual period was on 5th of June 2025. Patient has regular menstrual cycle of approximately 28 days. Patient had 2 full-term normal vaginal delivery and no history of any abortion. In summary, a 36-year-old female patient from Ahmedabad came with a complaint of neck swelling, which was painless and gradually progressive, without any pressure symptoms since 2.5 years, and was associated with a weight loss, protrusion of eyes, excessive sweating, tremors, intolerance to heat, and insomnia. Some of which was improved on medication with no significant past or family history.
Sir, are we allowed to go back to the history, sir?
Yes, yes, definitely.
Yeah. I saw somewhere that
Parth,
you
go to
said,
the first slide.
yeah,
Yes.
I mean, that's okay. Complaints spelling is wrong. Small things matter. COM, it is PLAINTS. I'm sorry, I'm correcting your spelling, but these are
Sorry, sir.
small things, nothing to do with the case. Next slide. See, I wanted to ask you, it's not in this. Did she complain of protrusion of eyes or was it something you noticed?
It was I noticed and inquire regarding sir.
So, which means it is not her complaint.
Yes, sir.
You know, only if she tells, see, my eyes feel a bit bulgy, then it is symptom. If you have noticed, it is a sign. So that's what I wanted to ask you. These are subtle things your examiners might not want. But when you say she complains of protrusion of eyes, unless it is so prominent, most people will not complain. So that is what I wanted to ask you. So
Yes,
it is
sir.
basically you picked it up and asked. She
Yes,
didn't
sir. I
complain.
picked it up.
So which means ideally it is not a complaint. My colleagues, please feel free to differ with me. Shah sir, Pankaj Modi sir,
No, no,
Yalagashi
absolutely
sir.
right, sir. No, no, you are right, sir. Nothing wrong in it. Weight loss of 10 kg over 2 years, is it important?
Uh, yes, sir. In thyroid condition, if it is
No, no,
associated with
no,
that.
no. See, you are right. You are associating your history with thyroid. What I
Yes.
am asking is 10 years over a period of 2 years. 10 kg over a period of 2 years. Is it significant?
Uh, uh, at present, yes, sir. I don't know the exact weight of patient as of now. So I would like to confirm it with whether the patient has 5% or more weight loss in last 6 years, 6 months. Sorry.
The other thing you should ask
So
about.
when did the patient go to the physician? Yes, sir. Please, sir. Continue, sir.
No,
Please.
please, no, sir, no. You carry on, sir. My question will follow your question, sir.
So when did the patient first go to the physician?
Sir, 2 years back.
And before that, since when, how long the patient has complaints?
The patient had started complaints 2 years back. Followed after 10 to 15 days, patient went to physician.
Okay, so within 15 days, the patient went to the primary physician.
Yes, sir.
And there he did all the investigation and the medicines were started.
Yes, sir.
I mean, did she know that she had some thyroid problems with the first physician itself?
Uh, no, sir. Patient only said that the only some blood reports were done and medication was started. But patient has taking medicine inconsistently, sir.
But
When
she
you
is taking the medicines, right? And the
Yes,
same
sir.
medicine.
Yes, sir.
Okay, fine. See, why this is important is that 10 kg weight loss, what you say, now see the history, if you compile the whole thing, you said the patient had previously only history for 15 days when she went to the physician. It's a very rapid thing. See, nobody goes within 15 days to a physician. But anyway, she went to the physician, he picked it up. So her primary complaints were only for 15 days. And after that, she is consistently taking the medicine, sorry, inconsistently, but taking the medicine. And then over a period of 2 years, she is a weight loss of 10 kg.
Yes, sir.
Apurva bhai, may I add something?
Please, Saib.
Parth, that is as with the Sir Guru sir is agreeing, there is a lots of grammatical mistake. The swelling in front of the neck. Rather, the proper terminology is in front part of the neck. You are sitting in front of the computer, so both are away from each other. Swelling is a part of the neck, so it is not in front of the neck, in front part of the neck. That I want to correct.
Yes, sir.
Am I right, sir? Hello, Apurva bhai? Am I right?
Yeah, barabar. So the thing is that, yeah. So the thing is that over a period of 2 years, so I don't know, probably the medicine dosage was less, but 10 kg weight loss over 2 years, I would not say is very significant unless the patient is 30 kg or 40 kg weight and it was reduced to 30 kg. Then it is probably significant. It is 10% over 3 years, 3 months, right?
Yes, sir.
So
Can I ask
2 years. Yes, madam.
why you ask for a history of pain and fever?
I want to know whether it is associated with any inflammatory condition or any deeper structure, if any associated with the penetrance to deeper structure.
But when there is a history of more than 2 years, then is it important?
Madam, your voice is not very much audible. Madam.
ઉર્મિલા તમારો અવાજ બહુ ધીમો છે.
When the history is long of 2 years, then is it important?
Ma'am, if there is a sudden increase in size and associated with the pains, I would like to like to know that whether the hemorrhage is occur or whether the carcinoma has occurred with the infiltration to the surrounding structures.
See,
Okay.
see, pain and
Ask for the history of palpitation. There is no
Yes, ma'am.
complaint.
Yes, ma'am.
Okay.
see, pain and fever, you're basically, as you rightly said, you are ruling out thyroiditis. That is inflammatory
Yeah.
conditions, especially ruling out thyroiditis. For 2 years, I will not use words like penetration and all that. You know, short history, perhaps pain, but even that you will not get fever. Okay. Then when you say a patient takes drugs, don't use the word inconsistently, use the word irregularly. Medication is taken irregularly, not inconsistently. These are small things, you know, which will help you in your presentation. Okay.
Yes,
Why did you
ma'am.
ask for lower limb edema?
If it is associated with the thyrotoxicosis and particularly secondary thyrotoxicosis, it is associated with the cardiac manifestation. It can lead to lower limb edema due to cardiac failure.
Okay.
Any
Right.
other cause for lower limb edema?
It can also due to pretibial mixed edema.
Okay. Why is the history of diabetes mellitus important in this patient?
As primary thyrotoxicosis is an autoimmune condition, it can lead to diabetes mellitus in the young patients also.
That is not conclusively proven, but thyrotoxicosis and diabetes mellitus are two conditions where you have normal or increased appetite and you still end up losing weight. Okay.
Yes,
So
sir.
that is very important. Whenever a patient loses weight, you will think about common things: diabetes mellitus, maybe thyrotoxicosis, maybe tuberculosis, and obviously malignancy. In tuberculosis, you will not have increased in appetite. Whereas in diabetes mellitus and thyrotoxicosis are two conditions where appetite can be normal or increased, but still you'll end up losing weight. Okay?
Yes, sir. Yes, sir.
Parth, I have
I
few
think Professor
questions for you.
Yalagachin wants to have
Yes, sir.
say something.
Yes, yes.
Yeah.
Yes, Guru
I
Sundar Prasad.
appreciate. I appreciate you have put a very short and informative history, but here and there with few terminologies you need to correct. I wanted to know if the patient noticed swelling first or the symptoms first, which you did not.
Patient has noticed swelling first.
Swelling first. Is it important for the management point of view?
Yes, sir. If the patient has noticed swelling before the long before the symptoms has started, I would like to think about secondary thyrotoxicosis. If the swelling and symptoms are started simultaneously, then I would like to go for primary thyrotoxicosis management.
How does it matter to classify at this level of your presentation whether it is a primary thyrotoxicosis or a secondary? How does it important for the management point of view?
If at all it is a secondary thyrotoxicosis, I would like to treat the cause first.
Like,
So-
you mean there is some other cause for secondary thyrotoxicosis?
No, sir.
Then how does it matter for the management whether to classify at history level, is it a primary or a secondary? At history level. Okay. If it is a primary thyrotoxicosis, you are predicting that these are the patients who are going to respond to your treatment, medical line of treatment. If you feel that it is a secondary thyrotoxicosis, probably they are the one who may require later a surgical intervention.
Parth, what sir is asking is, you should go back to etiology. Why
Exactly.
primary thyrotoxicosis develop?
In primary thyrotoxicosis, there is a development of autoimmune antibodies against the thyroid TSH receptors. which leads to
Why?
increase.
Why they
Stop,
develop?
stop there, stop there.
Stop. Yes.
What will be the status of the gland in such, yeah, that answer is accepted. What will be the status of the gland in that scenario?
In status of the gland before the pathophysiology will be normal.
No. He has developed thyrotoxicosis and he has developed a goiter. What will be the status of the gland? It's a diffuse enlargement.
So, yeah,
You
but
got
I
the
think we're
point?
now dealing with history. Maybe we can
No.
sort of develop it when you go to
At
the
history
clinical
level
examination.
to differentiate between primary and secondary. Okay, second, you have mentioned protrusion of the eyes. It is better to mention it as a prominent eye, what she has noticed, rather than eyeballs coming out.
Yes, sir.
Okay, her relatives must have told that her eyes have become prominent compared to normal eyes.
In fact, according to
Okay.
the history, they have not told anything. He has found out. So that should not
Okay.
come in the history according to me, because that's what I asked them. They have never complained about protrusion of the eyes. He has observed and asked. So typically it should not be in the history according to me. History is what the patient complains, not what you ask and then the patient tells. That is not history. Okay.
Sir, I would like to differ. There is a thing like a leading question. When you are seeing the patient, you ask certain leading questions. One of them is that since how long you had an eye protrusion, or did you have, then patient may volunteer. So
prominent eyeball.
technically he is not wrong, I would believe. He must mention it if it is there. And when on asking a leading question, if patient says, yes, I have noticed, that is the thing. Sometimes it becomes very difficult if he doesn't mention it. Examiner asks you, have you asked about it? You should ask in history the leading question, negative questions. Those are the things. That's why the students are many times into whether to say it or not to say it.
Sir, you can ask.
Better to mention that it is a
Yeah.
prominent eyeball she has noticed or the relatives have noticed.
So probably
Sir,
she
these
has
are-
noticed, but I would not say she complained with,
Yeah, agreed.
That is what
Yeah,
I'm
yeah.
trying to highlight.
Yes.
See, that was not her complaint. You
Yes,
mention
agreed.
it in the history as a matter of fact. You have noticed, see, you have asked a question, but it is not a primary complaint. So your emphasis should be on primary complaint. That is what I'm trying to highlight, sir. Nothing else.
Yes, yes, sir.
Right,
Point
sir.
well taken.
You have mentioned
Parth,
that there is no
before we go further, what is significance? Actually, sir wants to ask, you are saying what I mean. What does, when the patient says patient has noticed only swelling in continuous of Vittal, sir? When patient says chief complaint is only swelling, what comes in your mind first?
If the swelling is from the swelling is for the long time, I would like to
Why you are saying long time? You have got the time limit. Since how long patient has got?
2.5 years.
That's it. That is what
Yes,
long time. So patient has a swelling since 2.5 years. So what gives you idea? What is the likely pathology?
It is maybe due to goiter.
Which goiter is very vague.
Diffuse non-toxic goiter.
Diffuse non-toxic goiter. And in your history, you found out the patient has also got the symptoms of hyperthyroidism, right?
Yes.
Since
Yes,
how
sir.
long patient has the symptoms of hyperthyroidism?
Since last 2 years.
Since that. So swelling appear first and the symptoms appear later. So what does it suggest?
It is suggestive. It is due to most probably to secondary thyrotoxicosis.
Secondary hyperthyroid. Why?
Because in case of secondary hyperthyroid, swelling may present before the long time, and according to after that, few some of the areas of autonomous nodule may develop, which lead to increased thyroid production.
Sir,
Sir Vittal, sir, please.
Sir, I know traditionally we teach. I didn't want to go into the history because I think this is something we have to talk later. But since this topic has brought, traditionally we teach in primary thyrotoxicosis, the swelling and the toxic symptoms appear more or less simultaneously. It is more or less. It is not at the same time. It may
Yes,
be
sir.
even. It is very important to note. It may be-
Simultaneously, that's the word. Yes.
It may be even few weeks later the symptoms may appear, because you can't expect the swelling and the symptoms to appear on the same day. Basically, within a short period of time, even few weeks is acceptable. Whereas in secondary thyrotoxicosis, The toxic symptoms appear on a long-standing goiter. So you should give some allowance for the duration. It's not that the swelling appears today and I get the symptoms today. No. I may notice the swelling today. Maybe in the next few weeks also I can have the symptoms. That is still primary thyrotoxicosis. Whereas secondary thyrotoxicosis means I have a swelling for 2 or 3 years or even longer, and then the toxicity appears, because this is something which you should have it clearly. Although we say simultaneously, it doesn't mean the same day or within next 2 or 3 days. Maybe few weeks is acceptable. That's what the important point.
So, Parth, what sir is saying, that it is not exactly book-like that there will be a symptoms and 6 months followed by there will be swelling. It differs patient by patient. But the point is that they usually close together. Depends upon the patient's education, his relatives. Sometimes swelling is noticed first and then it is correlated with symptoms. Sometimes patient has a symptom, but he or she is not aware of symptoms. But when the swelling is noticed, then the clinician or the relative or a general practitioner connect them together and consider that they are connected. So, but what sir wants to say, just to explain you, if it is a very long-term swelling and patient had a recent symptoms,
Yes, sir.
right, then you should think of secondary. But like a 2.5 year and 2 years, it goes in favor of primary.
Primary.
That's
Yes.
what the sir wants to.
And already I'm telling you, you have told about the protrusion of eyes. So when you say protrusion of eyes, you are almost invariably committing yourself to
For primary.
thyrotoxicosis. When you say protrusion, it means, without your knowledge, you are saying primary thyrotoxicosis. Secondary thyrotoxicosis, very rarely. According to books, it's no, but there's nothing called never in medicine. There's nothing called never in medicine. Very rarely you may have, but as far as the exams is concerned, as far as you are concerned, if it's eye signs are there, it is primary thyrotoxicosis. So you have to build your story accordingly. That's what I'm trying to tell you.
Okay, let us continue with that, because this is the time. Why in primary you will find eye sign, protruding eye, and not in secondary? Almost always.
In primary thyrotoxicosis, there is a formation of receptor and antibody complex, which lead to increase in IGF-1 level, which may lead to there is
saying the soul's good names are not important. Tell
dangerous,
me simple. Simple
dangerous.
words.
due to
IgM, IgE, don't go in that. Then
I
the
will ask you
examiner will catch you.
I will love to catch you on difference between IgM and IgG. Don't use words. Make us idiots. Think we are idiots and simplify.
Yes,
You
sir.
understand? This is not a theory paper where nobody is going to counter you. Here he will ask, what is IgM? Why IgM is increased? What IgG is not increased? And why the IgM is important? Don't fall in that trap. Answer simply. My question is, in a primary hyperthyroidism or a thyrotoxicosis, there is a protrusion eyeball, and you rarely find that in secondary. Answer simply.
Due to accumulation of retroorbital fat and accumulation of hyaluronidase.
Why?
I think we'll make it. See, basically, there is an antigen antibody reaction in the orbit or retroorbital region. So what happens? There is inflammatory cell infiltrate, basically mainly T lymphocytes. And what do they release? As you said, what do they release? They release fibroblasts. There's proliferation of fibroblasts, and that secretes your hydrophilic glycosaminoglycans. Hydrophilic means absorbs water. So what happens? There is increase in the retrobulbar pressure. Therefore, the eyeball is pushed. Simplify things. That's all.
The one more point I would like to add is the antigen acting on a thyroid cell is the same acting on a retrobulbar.
Exactly.
And that will be in a primary, what sir has said in simple word. Do you understand? That should be the answer.
Yes.
And let the examiner ask why there is a collection of retrobulbar. Then do you understand?
Yes.
Okay. So in this patient, what do you mean by protrusion of eyeball? What does it mean? Other name for that?
Exophthalmos.
You are right not to use word here, but just I am asking. So what is difference between proptosis and exophthalmos?
Exophthalmos is most probably due to thyroid related condition, and proptosis is due to other condition than thyroid.
That is, it is a more specific term. Even exophthalmosis is a type of proptosis. But
Yes.
when it is due to a thyroid condition, we use a more specific term. That's
Okay,
This-
the patient has these symptoms. What is the reason for these symptoms? Weight loss, that protrusion we have discussed, excessive sweating.
Due to high level of circulating thyroid hormones, and which lead to increase in sympathetic activity.
On which receptor thyroxine acts?
You use
I
some
don't know, sir.
drugs, no, to block those receptors. You use some drugs in the treatment
So beta
modality.
agonists, beta blockers we have used. So
What type of receptors in beta blocker? Like any particular blockers receptors? How many receptors are there when you use beta blockers?
beta 1 and beta 2.
Yeah.
which do you think is more important here? I know we use also non-selective beta blockers, but which is the receptor which plays a prominent role?
So
Beta.
beta 1.
Yeah. Let's carry on. I think we are still stuck in the history.
Next. Yeah.
You just said
what
about
is your
bowel.
thinking at history level? What is your thinking at history level? What do you think probably she has?
So probably she has a diffuse toxic goiter, most probably due to Graves' disease.
How can you say diffuse at history level? So what is the likely disease at history level?
It's a primary thyrotoxicosis.
Probably thyrotoxicosis. Is
Sorry,
it
sir?
not? Swelling and symptomatology of thyrotoxicosis she has. Okay. So
Yes.
looks like case of thyrotoxicosis. Yeah. Examination.
Okay. Can you come to the family history? Sorry. What family history did you ask?
If there is a history of carcinoma in the neck region due to thyroid or not. On also a history of any other carcinoma of adrenal glands or parathyroid adenoma or parathyroid nodule.
Why did you ask all those?
Probably due to it is associated with the MAN2 syndrome.
So when you are seeing, when you are classically seeing a toxic patient, will you ask about MEN syndromes? No, generally, I'm not saying you're right or wrong. I just see in a postgraduate examination, there's nothing called right or wrong. As long as you are able to explain your rationale, the examiner will accept. So it is just a discussion.
Also, sir, I would like to ask the patient of any autoimmune disease in the family history.
That is probably more relevant. And you won't say, you'll just say any family history of goiters, family history of thyroid carcinoma, maybe. Okay, but I will not go into multiple endocrine neoplasia. Go back to the other slide, previous slide. You know, okay. Next one. No, you asked for history of bowel movements. You said they are regular, if I'm not mistaken. Is that
Yes, sir.
important?
Yes, sir.
Why?
In the thyrotoxicosis, it can lead to diarrhea, increased appetite, and if it is due to hypothyroidism, it can lead to constipation.
Is it actually diarrhea or increased frequency of motion? Which do you think is more?
Increased frequency of motion.
I think that is more likely. That is, you will go to the loo more often. It's very rarely to have frank diarrhea. You may get. So I would use the word increased frequency rather than diarrhea. I hope my colleagues agree with me.
Yes, sir.
Yes, sir. Yes, sir.
Yes,
Yes, Urviben.
When was her
Yes.
last delivery? When was her last delivery?
Yes, sir, I agree also.
Yes, ma'am. When a medical endocrinologist agrees with a surgeon, We humbly are grateful, madam.
And her voice has been raised now. Great.
Yes.
Parth, when
And
was her last delivery?
Yes, madam.
Sorry, sir.
two things, that palpitation is not there and bowel and bladder movements are regular. That is maybe due to irregular treatment, but still it is surprising.
Oh.
Yes, Guru Sattappa sir, you were asking something.
Yeah, Parth, when was her last delivery?
So last delivery was
When was the
8
last-
years back. 8 years back.
8 years.
Okay, I think we are
Fine.
done with the history. So according to you, you are most probably dealing with a patient whom you think has got thyrotoxicosis, perhaps primary thyrotoxicosis. Am I right?
Yes, sir.
See, I will summarize what he is telling. Okay, let's go on to examination.
I have examined the patient under adequate light and exposure with a female attendant present after due consent. Patient is conscious, oriented to time, place, and person. Patient is well built and adequately nourished. Temperature is normal on palpation. Pulse rate is 100 per minute with regular rhythm and normal force and volume in the right radial artery. Sleeping pulse is 94 per minute. Blood pressure is 120 by 80 millimeters of mercury in the right brachial artery in sitting position. Patient's BMI is 22. Karnofsky scores is 90. Patient's palms are moist and sweaty with staring look. Tremors are present. Oral cavity is normal with no clubbing, pallor, cyanosis, icterus of any lymphadenopathy. I have examined the patient in the sitting position from front and back. On inspection, a butterfly-shaped swelling present in the front of lower neck with horizontally extending beyond the sternocleidomastoid muscle on both sides, with vertically extending from superior border of thyroid cartilage to suprasternal notch inferiorly. With smooth surface and well defined margin, swelling moves with deglutination with inferior border is well visible. There is no scar, sinus or visible pulsation, no dilated veins, no other visible swelling in the neck. On palpation, inspectory
No,
findings
we
were
will
confirmed.
stop here. Shall we stop here?
Definitely, sir. If you have any questions,
Yeah.
please.
Come back.
We'll have a GP, general physical examination. You can, GP will have some discussion, sir.
Sure.
General physical examination. Yeah.
So when you mean sleeping
when-
pulse rate, why did you ask for a sleeping pulse rate?
Sir, as of now, I would like to differentiate with if it is due to anxiety or any other condition versus thyroid or not. If it is due to thyroid condition, sleeping pulse rate might be increased, and if it is due to anxiety, sleeping pulse rate is decreased or normal.
I'm not saying you should
explanation
not.
is right, but how did you do in this patient? Sleeping pulse rate, how did you do?
Sleeping pulse rate, I have measured for 3 consecutive
How
days.
did you do it? You went in the
Parth
midnight
sir
when she
is
was sleeping.
asking.
When did you do it? He's asking when did you do it? That's what
So
he's
how
trying to
will
ask
you do
you.
this? It is in lying down position or something else?
No. When did he do it, sir? When
When?
did he do it? Did he go
What
in the
time?
midnight around 1 o'clock and check the pulse rate, her patient's pulse rate?
No,
Did
I
you
have
do
attached
that
monitor.
in this patient?
You have a? How did you measure?
In the monitor, sir.
In the
No, in the
monitor.
sense at 1 o'clock when she was sleeping, you have put a pulse oximeter and recorded pulse rate. You did that personally.
Basically,
Not personally.
who did it? Doesn't matter. You can say even the nurse did it.
Nursing
It's all
staff,
right,
yes,
nurse.
sir.
Was it
So-
done like that? In the midnight, nurse went there and put the pulse oximeter and then recorded pulse rate. Was it done like that?
Yes, sir.
No. Why I'm asking, theoretically, yes, your explanation of theoretically is right. But has it been done? Has it been done for this given patient? So, because earlier that was the only way where we used to conclude that yes, patient is under control for thyrotoxicosis when patient was on medication. But nowadays we don't routinely. But if you mention that, definitely examiner will cross check. Was it done? Okay. So
If
best
you-
way is if theoretically question is asked, how do you clinically find out that yes, is the toxicity is controlled? Then you can have the answer.
If you ask me, I would avoid that because
Exactly.
these are things which were done many decades ago when we diagnosed only clinically and treated them clinically. Nowadays, we have so many laboratory investigations. We don't touch a patient and treat a patient without your free T3, T4, TSH. So I will not tell anything unnecessarily and get caught. But if
Okay.
your
Partha, what is the
examiners
idea of-
locally
Yeah.
have told you to do so, please do so. But if you are doing so, you should be prepared for a question. How did you do it? When did you do it? All those will be asked.
I agree with the sir, and part beware, you are going to appear on the daytime and no pre-assigned case was there. So you should rather omit the night pulse rate in the presentation.
Exactly, exactly. What was the idea of mentioning patient is conscious, oriented to time, place, person for this particular patient? What is the idea?
If it is due to primary thyrotoxicosis, in which the CNS symptoms are more predominant, which lead to irritability and anxiousness, and
No,
also
they will be well oriented, they will be conscious, they will be oriented to place, person. Tell me one thyroid condition where patient can become disoriented and becomes maybe unconscious. One thyroid disease, because you have brought this in this discussion.
in thyroid storm, sir.
No, no. In thyroid storm, patient will be conscious. Only the hemodynamic status will be impaired. It is only the mixed edema coma, which is not relevant for this particular case. So
Yes.
best way is to avoid this sentence. Even for hernia also, you people will be mentioning this. Oriented to place, time, person. Okay, so you have to have a reasoning for presentation of this sentence in the general physical examination. Modi
Yes.
sir, it is only the mixed edema coma where they can have this something wrong with the orientation
Sir,
and unconsciousness.
One more thing, sir. In severe cases of thyroid storm, patient may be disoriented, may also be unconscious. So that is
But
also
clinical presentation, when they present the case, like when patient herself has given the history, everything she has told herself.
I am only trying to explain what you have said. When you have said the orientation bit, which condition, he is also right in saying severe case of thyroid storm in decompensated thyrotoxicosis in thyroid storm, patient can be disoriented, patient can be unconscious like myxedemasoma. So both are the answers. That's what I'm trying to say, sir.
So I agree with the sir, but this is the postgraduate presentations, and in the exams, such critical patients are not
Will
kept.
not be kept.
So rather, he can omit that sentence, because in thyroid crisis, the patient will be in the ICU or in the other place, not in the
Both in
board
the
exam
coma
or
also.
the exam.
Both in myxedema coma also will be nice.
Also, he is not in the exam. So while presenting the case with the colleague or discussing the case, not in the exam, but for the discussion that oriented to time place, it's okay. That suggests whether he's in the mixed edema or thyrotoxic storm or not. But for the exam purpose, patient is a very cool and calm, that are only kept. So he can avoid that sentence, that I believe.
Yes, sir.
But I will leave it to your local examiners because they are your guides. Because in the exam, you can always escape by saying, this is what we have been trained by our local examiners, and the external examiners will agree, because once our local examiner tells that, they can't blame you. So in this context, whatever your local chiefs or your local examiners say, please do the needful. We are just giving you an external input. Okay? Yeah.
So
I want to
basically,
comment.
those gray areas in the exam which are always there.
Yes, Urvi ma'am, you were saying something.
Yeah, I want to comment something that there are pulse rate was 100 per minute and the sleeping pulse is 94 per minute. That is also some controversy. And BP is 120/80. Generally, thyrotoxic patient has which type of circulation?
Hyperdynamic circulation.
Yes, then what is the finding of that? Pulse and blood pressure?
It is due to high blood pressure and collapse in pulse.
Yes, so your is regular rhythm, normal force, volume, pulse, and the blood pressure. What finding will be well? In hyperdynamic circulation,
What is
which type of
hyperdynamic circulation?
Uh, uh,
Parth, madam is asking pertaining to hypertension. In hyperdynamic, in thyrotoxicosis, what will be the type of hypertension they will have? Is it like
systolic or
170 by
diastolic?
150?
It is
170
systolic
by
or
110?
diastolic?
systolic is raised, diastolic is low.
The word which is used is wide pulse pressure.
pulse pressure.
What is that?
When the systolic blood pressure is raised and diastolic is low, it leads to wide pulse pressure.
How will you find out hyperdynamic circulation?
On the pulse rate, on the pulse, there will be collapsing pulse and
What is collapsing pulse?
Where do you get collapsing pulse?
Because I don't understand that. Maybe. You said twice, what is collapsing pulse?
You know how it is being checked? How it is being checked?
a rapid increase in the volume followed by sudden decrease in the volume.
Good, you're answering well. We are only threatening you, like America. Don't worry. Behave like Iran. Give us a blast.
Right. So what is water hammer pulse? Some old examiner is going to ask you this question.
I think that is a question of MD medicine exam.
But yes, as such, the collapsing pulse is also there. Yes, so whenever there is a hyperdynamic circulation, some in thyrotoxicosis case, some examiner may ask you. Apart from wide pulse pressure, how will you find out that patient has got a hyperdynamic circulation? That is by water hammer pulse. How will you examine for that?
I don't know, sir.
Okay. Madam, would you like to enlighten? Urvi?
Yes, sir.
Please.
Generally, these are the signs of hyperdynamic circulation. And, sir, we have to examine the patient.
Particularly what the old concept says, that you put your whole palm over the forearm of the patient and you will be able to find out what you call collapsing pulse or hyperdynamic. Okay, that is not but remember that. So how did you include sleeping pulse here? That's the question actually.
I've never seen it been included for ages. Anyway,
Pardon, sir?
No, I've never seen anybody include sleeping pulse in a toxic goiter for ages. I would forget about it.
That's not to be done.
In your case, the only thing about this blood pressure being normal is patient is already on treatment, but irregular treatment. So all the clinical manifestations may not be very distinct, So because the patient is already on treatment, that would be your answer to madam's question. That should have been your answer. Okay?
Yes. Yes, sir.
So did you understand? My question is that, did you understand what the sir said?
Yes, sir.
What did he say?
If patient is taking medicine, although irregularly, but it can lead to normal blood pressure and pulse.
One. Second point is that sleeping pulse rate, obviously in any exam, obviously you cannot take. You don't expect patient to be asleep. It is for a ward purpose. Do you understand?
Yes, sir.
And if it is a thyrotoxicosis case, then it should be higher than the normal pulse rate in awake condition.
Yes, sir.
What is more important is regular rhythm. Why the rhythm is important?
In thyrotoxicosis, it can lead to arrhythmias, which can lead to irregular rhythm or any drop beats.
What arrhythmia? Ventricular, atrial?
It can lead to sinus tachycardia, atrial fibrillation, or ventricular premature complex.
Sinus tachycardia, atrial fibrillation, It basically affects the sinoatrial node generally.
Yes, sir.
Madam, am I right, madam?
Yes, sir. Yes, sir.
Because I'm scared, you should not, we are going into madam's territory and we should not be telling wrong things.
No, sir. You are right.
Okay, carry on.
Okay, sir. you have written the spelling of starring is wrong, but it's okay. Doesn't matter. Tremors are present. What do you mean by that?
In primary thyrotoxicosis, one of the cardinal features is tremors or fine tremors, which will be elicited in the extended arm.
You should have mentioned fine
Hand
tremors.
tremors. Hand tremors.
Yes.
Hand tremors, fine in nature. What are the types of tremor, you know?
Fine tremors, coarse tremors, or the flapping tremors.
Where do you get flapping tremor?
In the hepatic coma or hepatic encephalopathy.
Where do you get coarse tremors?
In the disease like Parkinsonism
Where
and
else will you get? Have you
in
heard
the
about? Sorry,
anxiety and
anxiety. You will get coarse tremors. Okay.
Any liver disease other than alcoholic liver disease, which occurs in a younger age group?
Wilson's disease.
Wilson's disease.
Okay.
Wilson's. They will have
Any
coarse tremors.
any other tremor? You're told about coarse tremors. You're told about fine tremors. Have you heard of any other type of tremors? We are talking more medicine today. Have you heard of the terminology intention tremor? Where do you get intention tremor?
In the cerebellar condition, cerebellar ataxia, we give
So that's what you should
will
say. This is something, you know, because this is how they'll pick up, because examiners are bored. They can't ask the same question to everybody. At some point in time, if you come at the fag end of the day, they are already irritated. Okay. They will ask any type of question. Okay. Carry
You have
on.
mentioned about tremors. So where have you examined the tremors?
in the both with the extended arms, in the hand and in the tongue.
Yeah, so you should mention here that whether it is present in the hands or tongue also.
Okay. Fine tremors, how will you examine? Ideally, in the hand. Okay.
With the arm extended or extended on the front with keep and I will ask patient to keep extended arm for 1 to 2 minutes, and I will observe on the tip of the fingers.
The better way is, all this is okay. Please switch off the fan and put a piece of paper. You know, that is the best way of picking up a fine tremor. Coarse tremors are easier to pick up. Okay. So it's always put a small bit of paper, extend the arm, switch off the fan and do it. Okay.
Yes, sir.
Palm facing down all is the word when you say extending. And where do you look for a tremor? On a tip of finger? How can you look for that? How do no, not a tip of. That's why the sir has said is right. The tremor is so fine, if you see with the naked eye, you may miss it. Right? Why you need to extend your hand and that? Why can't you simply see with that?
I don't know the exact answer.
But you have done it?
Yes, sir.
So what are you looking for in tremor? So the word is a easy fatigability. What is that? What is that? Easy fatigability. Remember, the small muscles of the hand, lumbricals and introccei, are supplied additionally by sympathetic system. That's why the many function we can do, including surgery, at the spinal level without giving a somatic command. Right? And they are being affected by increased level of T3, T4, which leads to sympathetic overactivity and getting fatigability easily. So you have to give some amount of work, including extension and spreading of the finger, which will cause the fatigue of the small muscle of hand, and then the tremor will appear. So as soon as you do it, it may not appear. But unless it is a very high level of T3, T4, but most of the patients are under treatment. So keep it in mind. Unless you are seeing it, don't mention them, because that is the first thing that will go away with the treatment. So keep this thing in mind, please.
Parth, what is the idea of checking for this clubbing, pallor, cyanosis, icterus? Is it required for this?
In the thyrotoxicosis, it can lead to thyroid acropathy, acropathy which present as a clubbing.
Clubbing, or will they have some other nail disorders? What is plumber nails or a dirty nail?
I don't know, sir.
Yeah, that is the one you get, dirty nails. So they will have a vertical serrations over the nails in thyrotoxicosis, where dirt can sit there. They will have a serrations over the nail. Clubbing is not a common factor. That is called a plumber nails or a dirty nails. Can you see cyanosis in thyrotoxicosis? Icterus, can you see in thyrotoxicosis?
No, sir.
So it is not required in this particular case. Okay, so mentioning this like a routine for the completion sake in general physical examination is not very much required.
Yes.
Nowhere you have mentioned that there is no pedal edema in your general physical examination. That is more important, pedal edema, no pedal edema. Okay, if patient of thyrotoxicosis has a pedal edema, what will be the important associated symptomatology in such patient? If they have a bilateral fitting pedal edema.
A patient also can have breathlessness on exertion and palpitation.
Exactly. So keep a possibility of CCF, and invariably patient will be breathless. Okay. So that is the one important clinical examination you have not mentioned. Yeah. Next slide. What is the idea of oral cavity examination in this case?
If any lymph nodes or any other conditions are present,
Oral cavity examination. Okay. If the question is asked like this, what is the role of oral cavity in a thyroid disorder? May not be in this particular case. May not be in this particular case. Anything related with the tongue and the thyroid?
Yes, sir. There is a possibility of lingual thyroid.
Exactly. Not in this case, but just remember. So there is no need to mention oral because it is not a lymph node mass you are going to present.
Yes.
You got the point. So only relevance with the oral cavity or the tongue examination and the thyroid disease is lingual thyroid. Invariably, that will be picked up on evaluation by nuclear scans.
Yes.
Okay. So routinely, it is not required. Next slide. You have finished, done with the inspection, no?
Yes, sir.
Okay. Sir, shall we have a discussion on inspection palpation separately, or let him continue neck examination and then we'll come back to the discussion?
I think we'll have it then and there. Otherwise, we might forget.
Yes, sir.
Hello. Inspection, stop. Palpation, stop. We'll do that way, sir.
Before we forget, we should ask the questions.
Yes.
Okay.
Yes, sir. In inspection, a butterfly-shaped swelling present in the front of neck.
Hold on. We have heard that you have presented your inspection. You have presented that. My idea is it is a goiter, which is pathological.
Yes.
So pathologically enlarged thyroid gland cannot look like a butterfly shape. Butterfly shaped is described for a normal thyroid gland. Sir Vittal, sir, if I am wrong, please correct me.
You are never wrong.
Butterfly. No, sir. No. Butterfly shape is described for a normal thyroid gland. So once it becomes diseased, that shape gets altered. So don't use the terminology of butterfly shape, even if it looks. It may not be butterfly shaped. So it is a pathological thyroid gland we are describing. So
I will always say swelling front of the neck.
Exactly.
That's all I will say.
Exactly.
I will not commit more. Remember, in exam, you rather not commit things unnecessarily. You should make the examiner ask. You don't commit and then get caught. You know.
So at least we can say bilobed swelling.
Swelling in front of the neck and describe the swelling. Extent.
Sir, that you can say later on. You just say swelling in front
Okay.
of the neck now. And later on palpation, you can say, I'm able to feel this, both lobes are involved and all that. But I will say swelling in front of the neck. Probably you can say the extent. That is nothing wrong.
Exactly.
But I will not use butterfly. You know, basically, when you say extending beyond the sternomastoid, you are trying to tell me it is a big swelling. That's what I will think.
Yes.
Am I right?
Yes, sir. Yes, sir.
Yeah.
Next slide. I am happy that you have not mentioned for this case on inspection that it is not moving with a protrusion of the tongue, which every candidate mentions, irrespective of the size of the swelling. Okay, so don't mention that protrusion of the tongue and movement of the swelling up and down for a bigger swellings. Okay, it has got its own indications.
My only comment here is you mentioned swelling moves with degglutination. No, it is deglutition, or if you can't get that word, swelling moves with swallowing.
Yes.
What is the idea of scar sinuses here and the visible pulsation? Because sinus, why sinus you expect in a thyroid swelling? So don't mention routinely. And a
But-
scar, because she has not undergone any surgery. There is no history that she has undergone surgery in the neck in the past. You got the
Yes.
point. So if it is there, you highlight this point. If it is not there, don't highlight. You will be inviting problems.
Visible
Yes.
pulsation, I will agree.
Exactly. Yes, that can be accepted.
See, there are two ways when you're presenting. One is just say all the positive findings and relevant negative findings. Not say no history of everything. Some relevant negative findings are important, but finally it boils down to the particular examiner. While presenting, you should assess the mood of the examiner. If you feel he wants that, then you should not be stubborn. Our aim is not to argue with the examiner. Our aim is to pass the exam. Examiners comes in different shapes and sizes. You have to cater to the needs of the particular examiner on that particular day. So there's no hard and fast rule. Sir may say, I don't want. I may say, I want. So when you start presenting, if the examiner looks unhappy, then you should slightly change track. Okay? You should not be stubborn. You should tell what the examiner wants, not what you want. Understood?
Yes, sir.
Yeah.
Where did you look for dilated veins? Where exactly did you look for?
Dilated veins over neck and face region.
Face.
What was the idea of checking for dilated veins?
If there is a retrosternal extension of the goiter, it may lead to occlusion of thoracic inlet, which lead to obstruction of the inflow of the superior vena cava.
So do you
So where
find
do
the
we
name?
expect the engars?
Sorry, sir.
Where do we expect the engorged veins in such scenario?
On the lateral aspect of the neck.
Neck and upper part of the chest over the sternum.
Not in the face. Upper
Face will be
sternum and
swollen.
neck.
Yes.
Not on the
There's a
face.
SVC obstruction. Face will be swollen, not the engorged veins over the face.
Yeah.
Okay, so engorged
you-
veins will be. Bailey and Love has got a beautiful photograph, no? One clinical photograph he has put, Bailey.
You will have facial congestion. You may have cyanosis as well, but never veins on the face. Veins on the neck and the upper part of the chest, mainly in the sternal region.
Yes, sir.
Okay, fine. Next. You have not done a video for this movement with the degradation.
No, sir.
You should have put. You should have put
Yes.
that one short video of movement with the degradation. Okay.
Yes.
What was the idea of highlighting that the lower border is made out on deglutation? What was your idea?
My idea was to demonstrate on inspection there is no retrosternal extension.
Okay, fine. Next, palpation. You present the palpation now.
On palpation, there is normal temperature with swelling is non-tender. On horizontally, swelling is extended. The medial border cannot be palpated separately. Vertically, from superior border of thyroid cartilage to sternal notch, right lobe is 6 by 4 centimeter in size and left lobe is 6 by 3 centimeter in size with smooth surface and firm in consistency. Lower margins are well palpable. Swelling is moving with deglutination and side to side mobility is present. There is no fixity to skin. Bilateral carotid pulsation are palpable at the normal site. Trachea is centrally placed. Palpable thrill is present over the upper pole of the swelling. There is no other palpable swelling present.
Before I forget, thrill means palpable. So you never say palpable thrill. It's like saying auscultatory bruit is heard. So you say thrill is present. You don't say palpable thrill. Just like you
Yes.
say bruit. Okay. Before I forget, I want to tell that.
Yes.
Okay. Once again, you're using deglutination. Just now I made a correction to you. You know, if that word doesn't come, make it simple. Swallowing. We will not penalize you.
Yes.
Are you presenting your palpatory findings separately for the right and the left lobe, or are you presenting as a single swelling in front of the neck?
I'm presenting as a single swelling in the front of neck.
Then why did you mention the medial border is not felt, left lobe is this, right lobe is this? You cannot. It's a single swelling. It is the
Yes.
extent from one sternocleidomastoid to other sternocleidomastoid, thyroid cartilage to suprasternal now.
Yes.
So you cannot highlight that the medial border is not well felt. No, don't do this. Shaw sir, probably they should not present as a separate two lobes. They have to present it as a single swelling.
Single lobe, yeah.
Yeah, single.
And
swelling.
then, if required, they can individually describe the node. Lobes.
That is what I
In the
always.
case of
Yes, sir. Yes, sir. I agree
in the
with
case of single swelling in front of the neck.
because
like
thyroid is one organ. That's what I tell
Exactly.
my patients. There's no such thing called right lobe and left lobe. It is one organ. It's like the nose. I tell the patient with left nostril and right nostril. You know, you present as a single swelling, but you can say features of the right lobe and features of the left lobe.
Hello.
That's the way I would do it.
Yes,
sir.
PRM sir.
Correct. Next line. Next line.
There
No,
is a
no,
resonant
previous,
note is
previous,
heard on the
previous,
Previous.
There are few things which wanted to highlight. Okay, no fixity to the skin. Again, if it is there in your examination, you highlight that point. If it is
Yes.
not there, don't unnecessarily. You will be inviting some questions. Okay,
Mhm.
and you mentioned the pulsations of the carotid are felt normal side. Where did
What
you
is the
palpate?
normal
Please.
site?
Where did you palpate?
The normal side is anterior border of sternocleidomastoid on the level of superior border of thyroid cartilage.
How did you how did you palpate?
On the seating position with the neck slightly flexed, I palpated on the anterior border of the sternocleidomastoid with the on the superior border of thyroid cartilage.
So basically, remember, any pulsation anywhere in the body, you will have to palpate against the bone. That's what is the most important thing. Okay, and you
Yes.
don't do it bilaterally together. That is number one. What is the significance of your statement? Palpable at the normal side. What are you trying to tell me?
Uh, bilateral carotid pulsation are the palpable at the north side and not displaced laterally by the swelling or not encased by the swelling.
Okay, if it is displaced, what does it mean?
If it is displayed, which means the swelling is large and it displaces the carotid sheath laterally.
Okay, what is the other thing you mentioned?
If it is due to carcinoma and which leads to infiltration of the carotid sheath, the pulsation will not be palpated.
So what do you call that?
The Berry sign.
Okay,
Where,
carry on.
where will you palpate the normal pulsation, carotid pulsation?
Normal pulsation is palpated at the is against the tubercle of C7 vertebra. Sorry, sir,
How will you
C6 vertebra.
find? How will you find? Oh, this is C7. Agreed. Also call it tubercle, carotid tubercle. Fine, but how will you find it? Oh, this is the site where I will find the tube.
It is the
Because
most
then
prominent.
only will know whether it is a displace or not palpable.
Sir, he mentioned drawing a line from the superior thyroid
Yeah.
cartilage to anterior
So
border.
there are
of
two, upper border of that and upper 1/3 and lower 2/3 of anterior border of sternocleidomastoid.
The junction of the
These
upper
two
one.
line. So you have to
which
be very
carotid we are
specific.
talking about? Parth,
Sorry?
which carotid all of us are talking about now? Which carotid?
Internal carotid arteries.
Oh.
That's where you need to do.
You are caught now.
Yes, exactly. What is the anatomical relation to carotid and the thyroid in the anatomy when you study anatomy? Which carotid has got a relation?
A common carotid. Sorry.
Exactly.
So,
What all of us are talking about is the common carotid artery.
If you know that,
If carotid is not filled, when you examine a goiter and carotid is not filled, what is that next examination will be doing pertaining to vascular system?
I would like to palpate the carotid on the other side.
Okay, on the non-palpable side, what is that you will be doing it? What is the next vascular examination you will be doing it? To know that yes, patency is there or not there.
Uh, Carotid Doppler.
No, clinical examination.
examination.
I don't know, sir.
To know if it is a common carotid, to know that the luminal patency, which is clinically accessible in relation with the common carotid. Distally.
External carotid.
How do you know external carotid? What does it do further once it goes up?
What are the branches of the external carotid? Which branch?
Which anesthesia people will be doing it, no? When they give GA. If the hand is far away.
The temporal artery pulsation.
That is called
Okay.
superficial temporal artery.
superficial temporal.
Temporal
Don't
artery.
say temporal.
Yes.
Fine. Yeah, next slide.
What is the
Like,
importance
sir,
of trachea? Trachea is centrally placed.
If the swelling is large, trachea can be deviated laterally, which can lead to difficulty in breathing.
Just
Or
sorry,
Is it?
I'm very spontaneous. Just say, just because trachea is shifted, it doesn't need to difficulty in breathing. Okay, it only means one lobe is bigger than the other. Okay, that is the significance. Huge goiter, trachea can be centrally placed when both lobes are of equal size. It is one lobe is bigger than the other and pushing it. Just because it is pushing it immediately doesn't mean difficulty in breathing. Don't commit. That's what I'm trying to tell you.
yes. On percussion, a resonant node is heard on the manubrium sterni
What
and
is
on
the...
oscar.
Well, stop. What does it mean? Resonant
There
node.
is no
What are you trying to
retrosternal.
tell me?
There is no retrosternal extension.
Okay.
On auscultation, bruit is heard over the upper pole of thyroid.
Why do you look for the bruit in the upper pole of the thyroid and not in the lower pole of the thyroid?
Because sir, in the lower pole of thyroid, the inferior thyroid artery is coming from the posterior aspect of the thyroid, which is masked by the thyroid enlargement.
That is not the answer. The answer is you look at the upper pole because superior thyroid artery, number one, carries the bulk of the blood supply to the thyroid. Number two is a direct branch of the external carotid artery. This is the answer. Okay, I don't want to waste time.
Yes.
Okay.
Can there be a dullness over the sternum in spite of lower border being felt in a case of a thyroid swelling? Not this case.
Yes, sir. If it is due to primary mediastinal goiter, it can lead to dullness over the manubrium sterni with
In a case
palpable.
of neck swelling, neck goiter, can there be a dullness even though there is no extension of lower border? Okay, fine. In malignancies, no, where there are nodes, mediastinal nodes, more so in a papillary CA. Fine. Next slide.
There is a stare loop with infrequent blinking and wide palpebral fissure with lead retraction is visible with upper and lower sclera.
What is that point called? That scleral point called?
Sorry, sir.
What is that point around the sclera called?
The one you can see.
So it is
Exactly.
inspection of eye only.
Fine.
Yeah.
Limbus.
Limbus.
See, the corneoscleral junction is called the limbus. That's what it said. Remember, many of the examiners may be fond of all the names. So you should memorize. Personally, I am not a big fan of these names, but it all depends upon the examiner. You should remember, go and read about all the signs of the eye manifestations of toxicity. Like starry look is called Stellwalk sign. So things like that, because some of the examiners will definitely ask you.
Yes.
Sir, PRM sir, whether you look only at the eye or something else.
Sir, I have done both all the signs by inspection and palpatory method also.
What are the signs you looked after? When you mean all, tell me what did you? I mean, I'm not
Yes, sir.
asking the names. What are the maneuvers or what did you elicit?
In Dalrymple signs, there is a lead retraction is visible on one Graffry sign. There is a lead leg. On Stelweck signs, there is stared look with infrequent linking and wide palpebral fissure. On Mobius sign, there is a loss of convergence. And on the Joffrey signs, there is a loss of wrinkling while the upward movement of the eyeball.
All these eye signs are due to what? Some of them. Why do you have the wide and palpable fissure?
Due to sympathetic activity in the smooth muscle part of the levator palpebri superioris muscle.
Okay. Carry on.
Yes.
Guru Santapa
Systemic.
sir, you are saying, Guru Santapa sir, you are muted.
Yeah.
You say
yeah,
something,
sir.
I think.
Sir, yeah. In the examination, during examination, mentioning all these names of the eye signs may not be very much asked, and we expect you people to know. But only thing you should know, what is like what Vittal sir was mentioning, what is the reason why they are there. That's all. Okay.
Yes.
Next slide.
Just before we proceed, you said there is exophthalmos. You said, am I right?
Yes,
Or
sir.
have you not mentioned?
Sorry, sir, I forgot.
See, that is something you should mention. When you're
Yes.
talking about toxic primary thyrotoxicosis, when you're measuring, when you're talking about eyes, you have to mention the word exophthalmos.
Yes.
Strictly speaking, how will you measure exophthalmos? Is there any objective way of measuring?
Yes, sir. There is a exophthalmometer is there called Giger-Muller's exophthalmometer.
Okay, carry on.
Yes.
Next slide.
A systemic examination is normal.
Oh, fine.
In cardiovascular
particular-
system,
Parth, sorry to interrupt, sir.
yeah,
Yes.
yeah.
Did you discuss a difference in eye signs when we are talking of primary and secondary? Will it
No,
be
sir.
same or totally absent?
No,
In
sir. In
secondary
secondary,
hyperthyroidism, will there be eye sign?
yes, sir. But only due to sympathetic overactivity and
What
not due
will
to
there be?
Dalrymple sign and von Graff's sign.
Dalrymple sign will never be there. Dalrymple is a combination of exophthalmos with sympathetic overactivity, giving a typical frightening staring look, which will not be there in secondary hyperthyroidism.
You will never have prominent eyes. If you say prominent eyes, it is primary.
It is primary. So what will be there in secondary?
Stelweck signs and
Why don't you name them? Forget about this doctor's name. What are those signs?
Infrequent blinking and lead leg.
Lead leg and lead spasm. Von
Because-
Grafe and Stelweck.
Because these are because of sympathetic overactivity. Remember that. It's very easy. Okay. Forget the names. Remember the cause.
Exactly.
Yes.
So these are because of the sympathetic overactivity, because increased level of T3, T4, which will be present in primary as well as secondary. In primarily, they were made more accentuated because of the associated retrobulbar deposition, which will give rise to exophthalmos. So in secondary, you don't find exophthalmos, but lead leg and lead spasm may be there. Second point is most of the patient will come with some kind of treatment which will cause the T3, T4 come to normal. So most of the time in secondary hyperthyroidism, you will not find any eye signs. Whereas in spite of treatment in primary hyperthyroidism, you still will find the prominent eye and exophthalmos. That's why it will be there. And that's why we say in a primary, you will always find eye signs in spite of treatment. Why?
Because, sir, in spite of treatment, eye sign may take longer to recover.
So will it recover with antithyroid drug? Will the exophthalmos recover with antithyroid drug?
Only the sympathetic, only the part which due to sympathetic overactivity will recover, and due to exophthalmos, it won't recover without any
Yes.
surgery.
That's the point you should always remember. And that is the reason with a prominent exophthalmos, a treatment may even worsen it many a time.
In
You
fact,
understand?
in fact, we should discuss this later.
Yes, sir.
Antithyroid drugs does not cure the disease. It
Yeah.
only controls the disease.
Okay.
Remember that. Okay. Antithyroid drugs is waiting for remission to happen. In the meantime, it keeps you comfortable. That's all.
Please, sir.
Okay. Cardiovascular system, what did you look for? Quickly.
Pulsation and cardiac murmur and heart sounds.
Okay. Central nervous system, what did you look for?
Consciousness or orientation. Is there any irritability or anxiousness is there, or hyperexcitability is there, or
You should mention
muscle
tremor.
weakness?
Most important is tremor.
Tremors, yes.
That is the
Yes.
first thing. The next thing, some of them will have hyperreflexia. These are the two things. Madam, hyperreflexia, am I allowed to mention, madam?
Yeah, sure, sir.
Yes. So these are the two things. As Professor Yalagachan sir already mentioned, consciousness oriented and all is very rare. Neurologically, you first look for tremor, you look for reflexes, and then patients, generally you ask them, patient will have insomnia. These are the common things. Common things are always common. Okay.
Okay, let us go to diagnosis. Now give the diagnosis. Okay, summary I think we'll skip.
We all know the summary.
Hmm.
Okay, skip.
So my provisional diagnosis is diffuse toxic goiter or Graves' disease.
First of all, Graves' disease, the apostrophe should be coming after yes. I am becoming now an English teacher rather than your student because his name was Graves. So the apostrophe should come after yes, not before yes. Only if his name was Grave, then it should come. Okay.
And
Yes.
G should be capital.
Yes.
And it is Graves S. S is 2S, so that's why apostrophe is there. That's what sir wants to say. So it's not grave disease. Yes, it is a grave disease.
It is a grave.
Get
It
the
is
point, but yes.
exactly. It is a grave disease, but it is a Graves disease.
Okay.
And it should be diffuse toxic goiter, possibly due to or likely possible Graves' disease.
Yeah. What are the other names for
Cause
Graves
of
disease?
diffuse toxic goiter.
Bestos disease or Paris disease.
Other name: primary thyrotoxicosis, diffuse toxic goiter, Graves disease,
Bestos disease.
exophthalmic goiter. Why
Yes,
is
sir.
it called Graves disease? Who was Grave? I know who was Grave. Who
I don't
described
know,
it
sir.
first? Okay, to cut things short, it is initially described by an Englishman called Parry. He's from Bath. A little bit of history. Although he described it, he never presented it. This was in somewhere in the 1780s or 90s, I can't remember. But an Irish physician called Sir Robert Grave described it somewhere in 1835 or 1839. Because he published it, It is named after Graves, although it was initially described by Parry. At the same time of Graves describing it, a German physician called von Basedow, V is pronounced as Fa in German. So it's not von Basedow, it's von Basedow. So von Basedow described it at a similar time as Graves. So in the Europe, it is called von Basedow's disease. In USA, in UK, in English-speaking countries, perhaps it is called Graves' disease. The other terminology should be primary thyrotoxicosis or diffuse toxic goiter. Okay?
Yes, sir. Good.
So
Great.
why did you say this diffuse toxic goiter is due to Graves' disease? What are the other causes of diffuse toxic goiter?
Diffuse toxic goiter can be toxic multinodular goiter.
Then it is not diffuse.
So why you call it Graves' disease?
You said it is smooth.
So
Yeah,
I will tell you what are the other causes of toxicity in a diffuse goiter other than Graves' disease. Graves' disease is autoimmune, you can call
Yes.
it, right? So
Yes.
that's madam is asking. Other than that, other maybe autoimmune or nothing. Have you heard the word Hashimoto thyroiditis?
Yes, sir.
So can it have a diffuse toxic goiter?
Yes, sir. It can have a diffuse toxic goiter with a hyperthyroid presentation in the Hashimoto thyrotoxicosis.
I'm sorry. Now I have to interrupt. You said everything correct, but you said Hashimoto's thyroiditis with hyperthyroidism. That is wrong. Now tell me what is hyperthyroidism and what is thyrotoxicosis.
Toxicosis.
Let's come to the basics now. Now this is what is called committing yourself. Now you have given me enough joy to question you. What is hyperthyroidism? What is thyrotoxicosis?
Hyperthyroidism is a state where thyroid is producing excessive T3 and T4, and thyrotoxicosis is the biochemical and physiological state where raised T3 T4 level produces the physiological pathological symptoms.
You are reasonably right. Hyperthyroidism means the thyroid gland is overworking. Overworking means there is increased synthesis and secretion of thyroid hormones. That is hyperthyroidism. Thyrotoxicosis means a state in the body where the body is exposed to increased circulating thyroid hormones. All that is correct. In Hashimoto's thyroiditis, there is no hyperthyroidism.
Yes, sir.
In Hashimoto's thyroiditis, there is a destruction of the follicular cells which releases the preformed hormones. So there's a transient thyrotoxicosis. So you should not use the word hyperthyroidism in Hashimoto's. Have I made myself clear?
Yes, sir.
Madam,
how you differentiate between Graves' disease and Hashimoto's thyroiditis? Why this patient is not having Hashimoto's thyroiditis?
As the patient has a longer history since last 2 years, I would like to keep my diagnosis as a Graves' disease. In cases of Hashimoto's thyroiditis, there is a transient increase in the thyroid hormone, which lead to thyrotoxicosis. Then there is a hypothyroidism, which after the complete
this kind will not be present in Hashimoto's thyroiditis, which is present in this patient. Yes,
eye signs.
that's what answer I want. And other than Graves' disease, where did you see this eye sign? Exophthalmos, other than Graves' disease, do you see anywhere?
Proptosis. Where else will you get proptosis?
No, thyroid condition only.
Oh, thyroid condition. Where else?
I don't know, sir.
Sometimes it happens in hypothyroidism also, and so the terminology is this thyroid ophthalmopathy. So
Yes.
rarely it is seen in hypothyroidism also.
Yes.
And remember, exophthalmos is usually bilateral. Sometimes, although it is bilateral, it can be asymmetrical. one eye can be more prominent than the other. Very, very rarely it is unilateral. So exophthalmos is usually bilateral, can be asymmetrical, almost very rarely unilateral. You will not mention unilateral. So exophthalmos is bilateral. Sometimes one eye can be more prominent than the other. Okay?
Yeah.
Carry on.
How do you evaluate Bharat? Mark?
I would like to evaluate the patient first with the complete blood counts with serum thyroid profile in the form of TSH, T3 and T4 levels.
Okay, tell me what your results there. You are done. You must show us.
Sorry, sir, I don't have reports, but it will be the decreased level of TSH and raised level of T3 and T4.
Okay. Is there any other test you can do? Yes. The first thing you will do is a free T3, T4, TSH. That will roughly give you a diagnosis of whether the thyroid hormones are elevated. That's all. It doesn't
Yes.
give you an etiological diagnosis. Okay.
Yes.
Is
For
there,
the etiological,
thinking in terms of your condition, is there any other blood test you can do for
yes,
Graves'
sir. For
disease?
the etiological confirmation, I would like to go for anti thyroid stimulation hormone receptor antibodies level in the
What is
serum.
it called? What is otherwise called? The medical endocrinologist, madam, will call it TRAB, thyrotropin antibodies, or TSH receptor antibodies. How accurate are they?
I don't know the exact
Okay,
sensitivity
very,
specificity.
very accurate. 95 to 98% accuracy. In fact, number one, it is used to diagnose Graves' disease. Number two, sometimes you will have Graves you will have ophthalmopathy. Sometimes the goiter may come later, sometimes, or it may be so small you may not be able to palpate it. You can do this and confirm. Number third reason, to predict neonatal thyrotoxicosis in a pregnant woman. These are the utility value of TRAB. Madam, am I
Yes,
right?
sir. Yes, sir. You are right, sir.
In fact, for
And there is
Yes,
a
you
yes.
when you
there is
do
a one
clinical,
terminology which is called gestational thyrotoxicosis, which happens at the end of third trimester or at the end of first trimester, and it lasts up to the mid pregnancy.
Yeah.
And between this, there is a thyrotoxicosis, and these patients are also required to do TRAB to diagnose neonatal hyperthyroidism.
See, that is why I always confirm with madam. I don't want to say something wrong.
Yes,
Madam
yes,
is our
you are
guide.
right, sir. You are right, sir.
Yes, Guru
Absolutely.
sir.
Parth,
Yes, sir.
that's why when the question is asked in the exam, especially when you put the diagnosis, no, diffuse goiter, query Graves, it has to be put a query Graves, question mark. Because the only diagnosis for Graves disease when you demonstrate anti-TSH antibodies, then only that disease become a Graves disease. Unless
Yes.
you prove that, till then your clinical impression of Graves is a questionable one. So when your diagnosis, rightly you mentioned in the evaluation after doing a T3, T4, TSH, you have to check for anti-TSH antibody so that you will be proving that yes, it is a case of Graves' disease. So only when those antibodies are positive, then the diagnosis becomes it is a Graves' disease.
And what is the mechanism this TRAB present and they produce the thyrotoxicosis? Do you know that?
Yes, ma'am. That antibody acts on the TSH receptor on the thyroid
Yes.
gland,
Yes.
which produces the symptoms of thyroid toxicosis.
So they stimulate the thyroid gland like TSH.
Yes, ma'am.
Yes.
Fine. Next. And one more point, when the patient is on medications for thyrotoxicosis, the FT3, FT4 level estimation becomes a must. So when the patient is on drugs, otherwise routinely what we do, we don't ask for FT3, FT4 levels. We ask for only T3, T4 and TSH level and take a call on the management. But if the patient is on drugs for a manipulation, then FT3, FT4 levels becomes a very important role to know exactly what is happening. Is it a FT? Sometimes T3, T4 normal, but FT3 is high and patient will have a toxicosis features. You got the point. So you
Yes.
need to mention FT3, FT4 levels when the patient is on drugs. Okay. Next line of management.
Because
the
there's a
further
condition
investigation?
called isolated T3 thyrotoxicosis.
Exactly.
And that is usually occurs, just because for completion's sake, usually occurs when there's a toxic adenoma, a toxic adenoma or an autonomic toxic nodule is the commonest cause of isolated T3 thyrotoxicosis. Okay, and remember, a hyperactive gland will produce more T3 than T4.
Yeah.
Remember that. Both T3 and T4 will be elevated, but a hyperactive gland will produce more T3 than T4, relatively speaking. Okay?
Yes.
Whereas in thyroiditis, or when you consume excess of thyroid tablets, your T4 levels will be more than T3. These are all relative proportions I'm talking. Okay?
Fine. What is the next evaluation now?
I would like to also evaluate patient if the thyroid receptor antibodies are not present. I would like to evaluate patient with the radioactive iodine uptake studies.
Directly to radioactive
Why
iodine?
radionuclide scan just now for this patient? You don't want to have other simple imaging systems before you plan for radionuclide scan?
I would like to go for ultrasonography Doppler study.
That is what you need to mention. No, why suddenly a nucleate scan? Okay. Yeah, USG thyroid. What is that you would like to know from USG thyroid? Be fast.
If it
be
is
fast.
if it is due to diffuse enlargement of the thyroid, or are there any multinodularity are there or not? And also I would like to know more about the vascularity of the gland.
How does it matter for the management to know is it a diffuse enlargement or is it a nodular enlargement? How does it matter for your planning of treatment?
If it is a diffuse enlargement, I would like to sorry sir, I don't know.
Okay, if it is a diffuse enlargement on sonography, which one you will be happy to treat? If it a diffuse enlargement or if it is a nodular enlargement?
Diffuse enlargements.
Exactly. They are the one who are, earlier I mentioned this point. They are the one who are going to respond to your medical line of treatment. Okay. So in this case, in spite of on treatment, the way you have mentioned TSH and T3, T4, it is not under control. Okay. One. Second, on ultrasound, if it is a nodular goiter, it is unlikely that it will respond to medical line of treatment and she may land up with ultimately the surgical treatment. The only treatment available, curative treatment available for a nodular goiter is surgical. That's what Bailey writes. It is the only modality is surgical. So it is very important to the good sonologist to know is it a diffuse enlargement or nodular enlargement. Okay, and a Doppler, obviously, it will tell us that what is the status of vascularity of the gland. And don't mention routinely like what you mentioned for a thyroids or a sonography of the thyroid, presence of lymph nodes in this particular case, because we are not expecting lymph nodes in this case.
Yes,
because we are not suspecting a malignancy in a thyrotoxicosis. Okay, now what is the role of nuclear scan in this? Because you have brought that point.
In the nuclear scan, it will differentiate between the grave disease and toxic adenoma versus toxic multinodular goiter.
Anything else?
Last question. For thyroid, what is the importance if it is, do you want to carry out radionuclide scan or not?
It is if there is a thyroid uptake is present or not. First, I would like to check that.
First, in this case, is it required to have a nuclear scan first?
If it is, if the antibody is positive, then thyroid uptake scan is
Antibody
not
is
required.
positive and USG is normal. Normal meaning a diffuse enlarged goiter.
Diffuse enlargement.
then it
Then you
it
don't
is
need
not
it.
required. Yes.
હા મેડમ તમે શું કહેતા હતા પૂર્વી મેમ?
Another thing what he likes to rule out in a thyroid scan. He said that whether it is diffuse goiter or nodular goiter or anything else will you look for in thyroid scan?
If at all uptake is present or not, or uptake is present
If
on
it is
the
a low
ectopic
uptake
side.
in a case of thyrotoxicosis, the scan is
if-
showing low, then
I would like to keep the possibility of there is a thyrotoxicosis, factitia, Hashimoto's
yeah,
thyrotoxicosis.
so it is a Hashimoto's thyroiditis is most likely in that case.
Yes, ma'am.
સર
Okay, nuclear scan, what is the role in this case? Is it really required?
No, sir, not required in this case.
Not required, not required.
Why?
Really,
Why?
Because my anti-thyroid receptor antibodies are present, so
If you
thyroid
have
scans are
not
not.
done, if you have not done that, then what is the reason?
Then it is probably required.
Because of the eye signs. Generally, eye signs is present in this thyroid, Hashimoto's thyroiditis. It is not present in Graves' disease. It is present, or hyperthyroidism. It is present.
this patient has been done? Nuclear scan has been done?
No, sir.
No, okay, fine.
જયેશભાઈ
Okay,
યસ કન્ટિન્યુ સર કન્ટિન્યુ.
any other investigation you would like to have?
Yes.
Okay, is any histological diagnosis is required for this particular patient?
No, sir, not required.
Not required because the patient has got thyrotoxicosis. Okay, you have a case here, sonography and
Sir,
TT
just one thing. Sir, just one thing. If at all you need a tissue diagnosis, when will you do it? If at all you need a tissue diagnosis, supposing there is some issue and you want to do an FNSA or FNAB or true cut, when will you do it?
Sir, you are asking with thyrotoxicosis or you are asking in
Yes,
general
sir.
for
Yes,
goiter?
sir. No. In thyrotoxicosis.
In thyroid. Parth, you understood the question?
Yes, sir.
Yeah.
If it is due to Hashimoto's, I would like to do a fine needle aspiration biopsy.
The point I want to raise is that it is better if you have the toxic the patient under control before going for some kind of stimulation to the gland, which can, I have not seen a patient, but which can lead to thyroid storm. Sir, what do you say?
Sir, for undergraduates, what do we expect if the diagnosis is with thyrotoxicosis of any goiters, FNAC and the histological diagnosis is not a must. Because there is a physiological alteration in the gland activity. So because the incidence of having a cancer in a thyrotoxicosis is very minimal, around 1%.
Very good.
So it is routinely not advisable unless you have a strong evidence on imaging, like in the form of a sonography, which is telling us that there is a nodule, which is indicative of a malignant nodule. Then only, otherwise routinely asking for a FNAC in a thyrotoxicosis, better avoid during examinations.
Sir, can I give my view, sir?
Please, sir.
Yes, sir, please.
For undergraduate, I will say no FNAC, as professor said. But one must understand at a postgraduate level, I may not ask, but clinically, practically speaking, even in a toxic goiter, if you have an ultrasound scan and if there is a suspicious nodule, best thing is to do an FNAC. But only thing, when you do an FNAC, make sure the patient is euthyroid. I can tell you, most studies nowadays say that the incidence of malignancy in thyrotoxic patients is around 5 to 10%, depending upon the studies. But I totally agree with sir, Exams is one thing, knowledge is some other thing, practical treatment is some other thing. For undergraduate, I will say no FNAC. For postgraduate, also I will say no FNAC. But if the examiner asks, if you, when will you do FNAC in a case of thyrotoxicosis, your answer should be, if I do an ultrasound scan and if I see a suspicious nodule in the ultrasound scan, I may do a FNAC, taking precaution that the patient is euthyroid, because there have been malignancies reported with thyrotoxicosis, and the latest studies say it ranges between 5 to anywhere between 8 to 10%. So this summarizes. In clinical practice, if you ask me suspicious nodule, I do it. For undergraduates, the answer is no. Postgraduates decide, depending upon the examiner, decide the answer. This is the practical answer I'll give you.
Yes, sir.
Right.
Yes, sir.
Thank you, sir.
So what will you do, Parth, for this patient? With all the reports, what all you have mentioned?
Sir, I would first like to start patient after getting complete blood count and liver function test. I would like to start patient on the tablet carbimazole for initially for
So
intensive
already
phase.
patient is on drugs. Already patient is on drugs. And unfortunately, you did not mention what drugs, what is the dose she is taking. You did not put that in the slides. Already she is
Yes,
on
sir.
drugs. So what will you do?
So as of now, patient is taking medication irregularly, and patient doesn't have medication with her. So I would like to start the medication as of now as for the intensive phase in the 10 milligram or TDS, and I would titrate accordingly within next 6 to 8 weeks and plan the surgery.
Before, one moment. Before starting anti-thyroid drugs, will you do any tests?
Yes, sir. I would like to go for complete blood count and liver function test.
Why do you want to do that?
Because in anti-thyroid drugs, there is a chances of a side effect, not those related, agranulocytosis, thrombocytopenia, and pancytopenia,
That is
and
one.
along with there is a high chance of hepatotoxicity in as in case of propylthiouracil, and so I would like to get a baseline liver function
So
test.
you will not get any hepatotoxicity in your carbimazole, is it?
Yes, sir. It is there, sir.
What
It
type?
can lead to
So
hepatitis.
what is the liver problem you get in carbimazole? What is the liver problem you get in PTU?
In PTU, there is a fulminant hepatic necrosis is there. So, which can
That's all. What do you get in carbimazole?
it is a hepatitis or
No.
or
Okay. I don't want to waste time. In PTU, you are rightly pointed, it is acute fulminant necrosis. In carbimazole, it is mainly cholestatic in nature. So, what are the adverse effects of anti-thyroid drugs? Number one, agranulocytosis. Number two, hepatotoxicity. In PTU, it's fulminant necrosis. In carbimazole, it is cholestatic in nature. Number three, rarely you might get vasculitis like
yes.
problems. So, these are the three important adverse effects. Okay, carry on.
When you will you use PTU?
Uh, if a patient is pregnant with the in the first trimester.
Why?
Then on
Sorry,
sir.
Madam is
why?
asking why.
Why?
Because from the carbimazole, it can lead to it is embryotoxic in nature. It can lead to aplasia cutis and choanal with esophageal atresia.
Good. So it is teratogenic in nature. It can cause aplasia cutis or esophageal or choanal atresia, but it's only for the first trimester. Because second and third trimester, you'll switch back to your carbimazole, because first trimester is the period of organogenesis. Okay. Since
Any
you are
other indication for PTU?
PTU acts fast. So where do you need urgent treatment?
In case of thyroid storm.
Yes, in thyroid storm. What is the other advantage of PTU? Now, it not only decreases thyroid hormones, what
It
else
can
does it
also
do?
decreases the peripheral conversion of T3 to T4 to T3.
Exactly. It inhibits the conversion of T4 to T3. Only thing, it is not as effective as carbimazole, and because of its toxicity, carbimazole is the preferred drug. Okay. Since we are talking about pregnancy, first trimester anti-thyroid drugs, PTU. Second trimester, what will you do?
If case is present in the second trimester, I would like to first make patient on euthyroid by tablet carbimazole and then plan for surgery in the second trimester only.
Role of radiation?
There is
Radioactive
no role of
iodine
radiation in pregnant female.
Exactly. If you want to do surgery, it's in the second trimester. Radioactive iodine ablation contraindicated in all three trimesters. Medicine, PTU in the first trimester, second and third trimester, it is carbimazole. This is thyrotoxicosis and pregnancy in a nutshell. Carry on.
This patient is having exophthalmos. Would you like
Yes.
to go for radioactive iodine therapy?
No, ma'am. It can lead to worsening of the thyroid ophthalmopathy.
Right.
So it is a relative contraindication for radioactive iodine ablation. Okay.
Yes, sir.
Carry on.
Then if the after 6 to 8 weeks, if the euthyroid state is achieved, I would like to plan surgery in the form of total thyroidectomy.
I just want to ask one small thing. You are thinking in terms of Graves' disease. Would you want to give some more time, or would you want to straight away go and do surgery? Because there are many schools of thought nowadays. I just want to ask your opinion. You are not going to be penalized.
To add
Sir,
to this, Parth, to add to this, yes, you said after control 6 to 8 weeks. For example, this today is Sunday, that is. Okay, you have done the last week TSH, it was showing thyrotoxicosis. Tomorrow you will be repeating TSH, it looks normal. So next Wednesday you will plan the surgery.
sorry, sir.
You have a controlled toxicosis tomorrow.
Yes, sir.
Previous TSH was 1 week back, TSH was low. So will you post the patient next OT day? In other words, will you operate on a patient immediately after the control of thyrotoxicosis, or you want to add some terminology for that?
I don't recall, sir.
Okay, you should have a persistent euthyroid status for a minimum of 4 to 6 weeks. Then only you should plan for a surgery for a treated case of thyrotoxicosis. It is not that the previous 1 week back it was low, then it has become normal today and you are operating tomorrow. No, that euthyroid status should be maintained minimum of 4 to 6 weeks, then plan for thyrotoxicosis. The complications of anesthesia and the post-operative complication, physiological complications, are more with a thyrotoxic surgery than a malignant thyroid swelling surgery. If the patient is not well prepared. Okay. So the funda is maintaining euthyroid status minimum of 4 to 6 weeks, then planning for surgery will have a safe outcomes.
Yes.
Okay. That should be your answer. How this total thyroidectomy, you have controlled everything nice. How this total thyroidectomy is different from total thyroidectomy for a case of MNG in euthyroid status? You understood the question?
Is
Yes,
it easier? Yeah. Is it more difficult? Is it less challenging? Is it more challenging?
Tell 1, 2, 3, 4, 5, 6 like this. How this total thyroidectomy is different from other MNG in a euthyroid status?
I don't
One,
know, sir.
it needs to be prepared. Second, you need to keep things ready for, even though you got a controlled thyrotoxicosis, can you expect some problems during intubation and during anesthesia induction, during giving position? Can you expect some problems?
Yes, sir. It can if thyroid hormone is released, it can lead to thyrotoxicosis.
You can expect. Second, third, that is anesthesia point of view. Third, once you are taken incision and started mobilizing, can you expect some problems versus the other scenario?
it can in Graves' disease there is an increased vascularity, so
So
increased
what is
bleeding
the
chances.
difference in doing surgery in this case and a euthyroid status case? You need
Uh,
to ligate the pedicles as early as possible.
yes.
You need to manipulate the gland as minimum as possible.
Mm.
Can you expect more bleeding in this case?
Yes, sir.
You can expect more bleeding. Is there any chances of hypoparathyroidism in this versus the other scenario which I have given?
Yeah, yes, sir.
More chances, more chances. So like that, is it a must to keep a drain in a thyrotoxic gland when you've done a surgery?
Yeah, yes, sir. Because there is a
It
large
becomes a
swelling.
must. It
Yes.
becomes a must.
See,
Like that, you should have differences all write down and keep ready with answers when the question is asked. There are good
just
number of
to
differences.
elaborate what sir said, patient should be euthyroid before surgery. So you have to take measures by not only giving anti-thyroid drugs, some most will need beta blockers, and many of us, although there's no real evidence, still give what is called Lugol's iodine.
Yes, sir.
What is the purpose of Lugol's iodine? It decrease. I'm telling the answers because of lack
Yes.
of time, because I'm also going to leave now. It makes the gland less vascular, makes it more firm. If you are going to give Lugol's iodine, you do not give it for more than 1 week or maximum 10 days. How does Lugol's iodine work? What is Lugol's iodine?
Lugol's iodine is 5% of iodine and 10% of potassium iodide.
Okay.
It's a mixture of that, and it works by Wolff-Chaikoff effect. It lead to thyroid constipation
It,
because
it,
of the
it does. Okay, carry on. Yeah, yeah.
because the iodine excess because the increased iodine excess, it leads to decrease in the uh, leads to thyroid iodide trapping and lead to a decrease in the formation of T3 and T4. Also,
Okay.
it decreases the conversion of T3 and T4 peripheral.
Very simply putting, high dose of iodine decreases transport of iodine into the follicular cell, decreases the synthesis of the thyroid hormones, and decreases the release of the preformed hormones. But this is only for 7 to 10 days. As you rightly pointed out, Wolff-Chaikoff effect is inhibition of iodine organification leading to decreased hormone synthesis. However, if you give for more than 10 days, there is a escape phenomena. So you normally give for 1 week, never more than 10 days. Lugol's iodine or saturated solution of potassium iodide, all of them are very bitter in taste. So you normally mix with milk or orange juice and is given thrice daily. If you are giving Lugol's iodine, give 5 to 7 drops. If you are giving saturated solution of potassium iodide, you give 1 to 2 drops. Okay? So you
Yes, sir.
make the patient euthyroid. That is very important. The other thing, it is an anesthetic challenge. Your heart rate may go up very high, so your anesthetist may usually have IV esmolol to bring the heart rate down. As sir said, the chances of hypoparathyroidism is high. Why? Not only because it affects the parathyroid, in addition, in thyrotoxicosis, you have what is called hungry bone syndrome. Increase in the thyroid hormones over a long period of time causes demineralization of the bones. But once you do thyroidectomy, all the calcium gets redeposited back in the bones, so you will get additional hypocalcemia as well. So your hypocalcemia is more marked after surgery for toxic goiter. Have I made myself clear?
Yes.
Okay.
Sir, one
Sir, you're muted. Hello?
Hello.
Can you hear me?
Apurva bhai, you may be log out.
Okay, you mentioned surgery. What surgery will you do?
I would like to go for total thyroidectomy.
Yes, nothing short of total thyroidectomy should be done. For some people may say near total, which is acceptable, but if I were the surgeon, I would always expect total thyroidectomy. Nothing
It
short
is
of.
from the postgraduates, the surgery, what is total thyroidectomy?
That's what I said.
Don't
I would
get-
expect
yes,
total
yes.
thyroidectomy.
Yes,
But
yes,
I know
yes,
some
fine.
people say near total, but I would expect only total thyroidectomy. Nothing short of that.
Sir, sir, complications of surgery and other things, I think we will do for the next class, because that itself becomes a big discussion.
No, I think we are
Chair, sir?
already 2 hours.
Yeah, 11, sir, 11, 2
11.
hours.
In fact, I promised 10:30. I'll
Yes,
have to
yes, sir.
leave. I'll
Yeah,
have
11,
to thank
yeah.
Professor
Thank you, sir.
Apurva
Thank you.
Shah. And where is my good friend missing?
Yeah.
Modi, sir.
Sir,
Modi.
for the last one question for the PG students, it was in the previously it was mentioned that thumb size tissue is to be kept behind. What
No,
was
sir.
the recent concept and why it is not to be kept there?
Sir,
Sir,
the
nothing
reason
short
that
of total thyroidectomy, sir. We will
nothing
not
short
confuse them.
because if
Nothing
you,
short of total thyroidectomy.
because if you keep a tissue, see the reason they say keep a tissue is they wanted to protect the parathyroids and not damage the nerve. Nowadays they say if you are only an experienced surgeon should do it. If an experienced surgeon does it, you can do it safely, because if you leave behind a tissue, chances of recurrent thyrotoxicosis is there, sir. That is the rationale for saying total thyroidectomy. I want to thank Pankaj Bhai as well, Apurva Bhai, and Madam,
Thank
Urvi
you.
Madam. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Okay.